Alrighty. Well, good afternoon, everyone. On behalf of the Southern Regional Disaster Response System, we'd like to welcome you all to today's webinar entitled Game Plan Chemical Emergency Readiness for the FIFA World Cup 2026. Before we get started today, we just want to address a few housekeeping rules. So this webinar is being recorded and will be made available on the SRDRS website and the DPH Train website. So if anyone you know couldn't attend it today, then they'll be able to see it on these websites directly. The chat feature has been disabled for all participants, so you will not be able to chat during the webinar. We have also disabled the speaking mechanism, so everybody will be muted throughout the webinar. If you do have any questions, there is a Q&A button that's at the bottom of the panel, typically where you would find or a type in the chat. So you're welcome to put your questions throughout the webinar today. Feel free to go ahead and type them out to our speakers as they are speaking. You don't have to wait until the end, and we'll be sure to address any of those questions as soon as possible at the end of the webinar. At the end of the webinar, there will also be 2 QR codes to obtain credits. The first QR code that you'll see is for CME and the CNE credit. You must scan the QR code and complete the evaluation at the end of the webinar by June 5th, 2026 in order to receive credit. The second QR code is for the EMS credit. So if you are EMS personnel or a pharmacist, there might be some additional information that's also in the QR code that you will need to fill out in order to obtain your credit. Now, I'd like to take some time and introduce our moderators and our speakers after going through a few slides. So the first one is the accreditation statement. So this activity has been planned and implemented in accordance and accreditation requirements and the policies of the Accreditation Council for the Continuing Medical Education through the joint providership of the Georgia Department of Public Health and Emory University. The Georgia Department of Public Health is accredited by the Medical Association of Georgia to provide continuing medical education for physicians, and it is a 1 CME credit. For the accreditation statement regarding the CNE, Georgia Department of Public Health is an approved provider of nursing continuing professional development by the Georgia Nurses Association, an accredited approver by the American Nurses Credentialing Centers Commission on Accreditation, and this activity awards 1 contact hours. For commercial support, this activity did not receive any commercial support, and we are in kind support for this activity provided by the Georgia Department of Public Health in the Clinical Education and Professional Development for Continuing Education contact hours. The planners and faculty for this activity did not have any relevant relationships with ACGME to find ineligible companies to disclose unless listed in the disclosure report. Now, what defines an ineligible company? The ACCME has incorporated eligibility information directly into the standards of integrity and independence in accredited continuing education. So companies that are ineligible to be accredited for the ACCME system are those whose primary business is producing, marketing, selling, reselling, or distributing healthcare products used on or by patients. So with that being said, I just want to go ahead and introduce a few of our speakers. So I am Dr. Nikolas Foresteire. I'm a medical toxicology fellow at the Georgia Poison Center and the Emory University School of Medicine. I'm currently completing my first year of fellowship at Emory while practicing as an emergency medicine attending physician at Emory University Hospital Midtown. I previously served as a chief resident in emergency medicine at the University of South Florida HCA Brandon Hospital, and my clinical interests include envenomation management, radiation and disaster preparedness, and the integration of addiction medicine with medical toxicology. We are also joined by Dr. Ziad Kazzi. He is the professor in Department of Emergency Medicine at the Emory University School of Medicine from 2014 to 2021. He is the associate medical director of the Southern Regional Disaster Response System and the co-director of the Emory Center for Advanced Emergency Care. He also serves as the assistant medical director of the Georgia Poison Control Center, and he is the president of the American College of Medical Toxicology. He has over 23 years of experience in chemical and radiologic emergency preparedness and response in the United States and internationally. We are also joined by Dr. Mark Kirk. He is currently a consultant at Chemical Threat Solutions, LLC since September of 2025, where he provides expertise in chemical threat preparedness and response. Previously, Dr. Kirk served in senior leadership roles with the Department of Homeland Security's Countering Weapons of Mass Destruction Office, including being a senior advisor for chemical defense from 2023 to 2025 and branch chief and program manager for the Chemical Support Branch from 2018 to 2023. His work has focused on a national chemical defense strategy, operational support, and countering weapons of mass destruction. We are also joined by Dr. Emily Kiernan. She is an associate professor in the Department of Emergency Medicine at Emory University School of Medicine since 2025. She has a prior appointment as assistant professor from 2020 to 2025, and she maintains clinical roles as an attending physician at Grady Memorial Hospital, as a medical toxicologist at the Georgia Poison Center, and an addiction medicine specialist at the Grady Medication Assisted Opioid Treatment Clinic, all since 2020. She also holds consulting privileges in medical toxicology at the Children's Hospital of Atlanta, serves as an airway physician at Emory University Orthopedic Spine Hospital, and is core faculty for both the Emergency Medicine Residency Program and Medical Toxicology Fellowship Program at Emory. We are also joined by Mr. Ricky Shutter. He began his career in 2012 in emergency management and CBRNE response with the United States Air Force, gaining hands-on experience responding to events such as hazardous material spills, aircraft incidents, and even a volcanic eruption while stationed in multiple U.S. locations and overseas. In 2018, he transitioned to the Air Force Reserves and started his civilian emergency management career with the Georgia Department of Public Health as an emergency preparedness specialist. He has supported District 82 through COVID-19 pandemic, and in 2022, he became a CBRNE planning and operations coordinator, working with the response agencies and health partners to prepare for chemical, biological, radiologic, and nuclear emergencies. So with that being said, I'm going to hand it over to Dr. Mark Kirk.
Thank you, Nicholas. Appreciate the introduction. For the next few minutes, I'm going to talk about three questions I want to try to address as clearly and practically as possible. The first one is, why should you care about this topic? And what are some of the things you should be worried about? Secondly, what challenges might you face in an incident? Um, and then thirdly, what actions have the greatest impact on minimizing consequences? So I'm going to start with, just from history and from current trends, is to really emphasize this point that chemicals used as weapons are a potential threat. They may not be the greatest threat. We have active shooters, we have IEDs and car rammings. Lots of things happen around special events, but chemicals should be considered as a potential threat. The reason for this is that, first of all, uh, people that want to harm others and want to create terror see chemicals as a potential weapon of use for that purpose. Secondly, they've been used extensively. And thirdly, they're readily accessible in communities, in some way more readily accessible than other weapons times. So some of the notable chemical attacks, so the Tokyo sarin attack happened in 1995, was a terrorist attack on civilians using sarin gas released into the subway. There's been assassination attempts in Malaysia and North Korea. There's been nerve agent attacks both in England and in Russia. And then there's been battlefield chemical use in Syria and in other places now, such as sarin and chlorine, against civilians as well, even though they were battlefield use. One of the sad things, World War I was one of the most devastating wars, and chemical weapons were used extensively during that war. After that happened, the international community really made it the norm to not use chemical weapons. And then later, there were treaties, and the Chemical Warfare Convention came along, and then the Organization for the Prohibition of Chemical Weapons. And many, many countries signed on to this. So there was an international norm to never use chemical weapons. But because of some of these incidents I've mentioned, and because of consequences that haven't really unfolded for people that have used it, the international norms have eroded now, and there seems to be a more interest and opportunity for chemical weapons to be used. And I don't want you to think about chemical weapons as just chemical warfare agents that were developed by the military. In your own community, toxic industrial chemicals can be used as weapons. They're immediately available in large quantities. Your challenge is really to look for what can you do to understand what are your unique chemicals that could be used in an attack. Next slide, please. And this is just a quick refresher of some things. Some that you might want to consider toxic industrial chemicals in your community, things such as chlorine, ammonia, hydrofluoric acid. The binary gas forming reactions, or when you mix two chemicals together, such as cyanide with an acid, can create hydrogen cyanide gas, or household products mixed together to create hydrogen sulfide, as we've seen in chemical suicides in the past. There's notorious agents, the cyanides and pesticides, and synthesized agents could be used, sulfur mustard or nerve agents, and then toxins as well. The next slide. And there's some scenarios just for you to consider, something to think about for planning purposes, that chemical attacks could be most effective in small scale attacks where there's public gatherings, crowded places, similar to how an active shooter could operate. And indoors is often a much more effective space for chemicals to be released. It could be also larger scale through chemical supply chain like trains, trucks, any kind of shipment or containers. UAS, drones with agricultural sprayers could release toxic chemicals over a crowd in an outdoor event. And then they can have release by cyber attacks on a facility so that it releases what's in the pipeline or the industrial facility. And finally, where chemicals are just used as part of a larger attack, where there could be small arms, IEDs, something that could direct people in a certain direction. You can go to the next slide. So those are just some things to think about as far as what you might encounter and how they might be deployed. I'd like to spend just a few minutes talking about the history uh, of previous incidents and what are the things we should expect to face. These 6 points come the from literature, from evidence-based disaster planning. It comes from previous incidents and studying those in detail, and it comes from exercises and more current incidents. And there's a repeating theme that comes up in every incident. And I would expect you when you're planning to think about these because you're likely to face these and build these into your planning process and training. First is delays matter. Time to action is the most crucial element for minimizing the impact. Uh, Providing treatments, just recognizing the problem, all of those, the faster you can do that, the faster you can save lives and minimize injuries. The second one is that responders are often operating within a fog of war. And when I say responders, I'm talking about healthcare providers, public health, and those on the scene. And during the early stages of an incident, there's a lot of confusion, chaos, misinformation, uncertainty. And part of the reason for that is in a chemical incident versus things like a traumatic injury, the identification, the problem may not be readily apparent, and it may take hours or even days before you can really clarify what exactly you're dealing with. Any of you that have been involved in any kind of exercises or real events where you've had an after action review, you know, number one on the list of things to fix is that the most consistent observation in all of these is that communication is inadequate. And I'd expect it in a chemical incident as much or more than any other incident. In addition, there's an immediate surge of patients, both at the scene and the hospitals and other places. So mass chemical exposure causes this sudden production of casualties and creating this scarce resource situation that will affect your triage, decontamination, and treatment of all the casualties. And finally, fear is predominant in an event like this. So chaos, misinformation, uncertainty just feed more fuel to that fear. And so it's really important to recognize that the public may behave in ways that are going to challenge your response because of the fear. Next slide, please. I think for a matter of time, I may go ahead and just pass on this. One thing I want to mention is that the time to recognition to action determines the amount of injury you have. And the faster you can do something, the less people that are going to be harmed. And I'll move on to the next slide in this. So before I talk about this slide, I just from the previous 6 points, it's pretty clear that focusing your attention on recognizing the problem as quickly as possible, communicating as effectively as possible, and then logistics, logistics, logistics. How do you mobilize resources are three key areas in planning. But those areas of planning are to prioritize impactful actions that everyone needs to take. And these are four actions that are quite impactful. And this comes again from evidence-based disaster studies. This comes from all of the information that shows the challenges we have, that these are potentially the most effective ways. And number one is to stop exposure by all means possible. That is, evacuate, shelter in place, decontamination, wearing PPE, any way you can to minimize the exposure. The next is treating the wounded. And this involves several things. The first, again, recognizing what you're dealing with as quickly as possible. It's then mobilizing expertise such as poison centers. It's paying attention to the ABCs first and foremost, and then mobilizing those resources like antidotes, the medical countermeasures, and making sure any caches are getting to the wounded as quickly as possible. All of this in a coordinated fashion to take care of as many people, doing the best for the most. The third one's the psychologically wounded and treating them. You have to pay attention to this in a chemical incident. Fear is rampant, and then having coordinated messaging that tries to help alleviate some of the fear can actually divert some patients away from that surge to the hospitals. And you need to come up with ways to manage that. These could be mildly poisoned patients, or it could be just people needing reassurance. And then finally, minimizing the spread of contamination is really important for the later effects, for additional casualties, and for the environmental impact that could be for months or years after an incident. And that is everyone's responsibility to really focus meticulous attention to not helping spread any of the contamination. So I'm going to stop at that point and turn it over. Thank you, Nicholas.
Thank you, Dr. Kirk. And everyone, hello. Thank you for joining us. We have over 250 people right now on this webinar live, and I'm glad to know that it's going to be recorded for others who have registered to watch it later. One of the things that I've learned from Dr. Kirk over the last 23 years of my career is the importance of recognizing a chemical exposure. And not only I've learned from him in similar presentations, but I've also had to encounter situations in my career where I had to face a cluster of illness and applying the principles that he listed, the delay in diagnosis, the difficulty in confirming the chemical exposure, led to me using toxidromes as a way to guide myself in the initial hours after an exposure to classify the exposure, try to manage it safely and effectively as best as I can while I get more information. So I think right now with Dr. Keenan and myself, we are going to go through that. Some of the toxidromes that we want to highlight based on personal experiences, based on historical events. We are not going to delve into too many details as a lot of this information is online and available. Rather, just try to highlight some of the important points from our perspective and our experience. And for that, I would like to start with turning it over to the first two toxidromes, Dr. Emily Kiernan. Dr. Kiernan?
Thanks, Dr. Kazzi. So Dr. Kazzi and I are going to spend some time in this next section discussing, again, what he said, toxidromes. Now, if you don't know, a toxidrome is a toxic syndrome or a constellation of signs and symptoms that give you an indication of potentially what a toxic exposure may be. Sometimes these clues that you get from your patients might be the only thing that you have to use in those first minutes or hours after a chemical incident. So it can be really important. So if you're in medicine, I'm sure that you have been taught these toxidromes before. Sometimes they have some funny mnemonics, but they generally will give you a list of signs and symptoms to look for that would indicate a certain type of exposure. However, as Dr. Kazzi alluded to, it's not always that simple, especially in a disaster or a mass casualty event. But this is one of the most important things that we can do early in the response to identify what agent may have been used. Because we know that in a lot of these events, a lot of times that initial agent is either misidentified or we just don't know what it is. And this can lead to misdiagnosis. It can lead to anchoring bias, inappropriate treatment, exposure of healthcare workers and first responders, and potentially life-threatening consequences. So this, again, is a really important thing that we can do early in the response. And so one thing that I always talk to my trainees about is that if something isn't fitting with the toxidrome that you have learned and memorized, then you really need to take a step back and reevaluate the entire scenario. It's really imperative in these situations that we stay vigilant, we try not to anchor from information that was given to us, and that we look at the patient in front of us to try and piece this puzzle together. So next slide. There we go. Okay, so we're going to try our luck with a case here. And this is an unconscious patient foaming at the mouth with pinpoint pupils. So let's say EMS called for 2 patients that are found with mental status in the park. On arrival, they're noted to have pinpoint pupils or meiosis, small pupils, and they're fairly difficult to arouse. There's no drug paraphernalia around, but the park has, we'll say, a reputation for some illicit activity. So the 2 patients arrived by EMS to the emergency department, and the paramedics tell the emergency staff that they gave some intranasal naloxone and that there was a response to it. So initially, this looked like an opioid toxidrome, pretty cut and dry. In the ED, despite doses of naloxone, the patients remained obtunded, and they were both ultimately intubated and admitted to the ICU. So later that evening, they're still getting naloxone, they're on the ventilator, really not coming around. They both start to have this diffuse sweating and diaphoresis, but no fever. They're given, again, just kind of repeat doses of naloxone, not a whole lot is changing, but they are starting to notice that they're a little bit more bradycardic or slow heart rate than we would expect. So they did get some atropine and responded to that. But again, progressively just got more and more bradycardic. Within about 18 to 24 hours, now we start to see this picture starting to evolve. So we have diaphoresis or lots of sweating, bradycardia, bronchorrhea, which is a lot of bronchial and airway secretions, and meiosis, so the pinpoint pupils. Now we're starting to shift that picture into something that looks more like that classic cholinergic or organophosphate nerve agent toxidrome that we learn about in the books. Ultimately, both of these patients became more hemodynamically unstable, were started on vasopressors, and then we later find out that this was actually a nerve agent poisoning. And so this was an event that was adapted from an event that happened in 2018 in Salisbury, England. The Scriples, who were the couple in the 2 folks in the top, were poisoned by a nerve agent that they got from contact with their doorknob. So they got it on their skin and ultimately decompensated over that 24-hour period. And eventually both survived, but had a pretty prolonged hospital stay. Next slide. Now, again, okay. This is not what we typically or classically think of as a nerve agent or an organophosphate poisoning. Typically, we think about, like Dr. Kirk mentioned, the events in Tokyo or Syria where there's hundreds of people, there is some sarin gas that goes off, everybody comes in with all of these respiratory secretions. But now we're seeing that we have someone who we initially thought looked like an opioid overdose, but it was actually a nerve agent poisoning. So how can we tell the difference? So if we look at our case, right, so our classic cholinergic sludge or dumbbell symptoms are things like salivation, lacrimation, urination, defecation. Our two patients didn't have any of that early on. There was a question of maybe they vomited after some naloxone. They did have small pupils. They did have a decreased level of consciousness. They were bradycardic, but there's none of that classic kind of respiratory secretions and respiratory distress that we typically think of in these cases. So I can see why this was considered an opioid early on, but at the same time, it didn't quite fit, right? Something was off, but enough of it fit. So we present that information to the emergency department and they anchor onto it. And now we admit them and treat them as an opioid overdose. One of the things that initially was fairly difficult in this case was that the EMS had told the emergency department that they had responded to naloxone. Now, a true response to naloxone means that they had a really low respiratory rate, which was never reported. And their response that they saw is that when they stuck the intranasal applicator in the nose, they kind of, woke up a little bit and then went back out. So not a true response to naloxone, but with that information and where we found the patient, again, we put this information together and went down one pathway. So even though we didn't have some of those classic cholinergic signs and symptoms early on, we really didn't put that part together. We just had something that looked similar to an opioid toxidrome, but maybe didn't fully fit. Next slide. So again, when we learn about these toxidromes and we see them side by side, it's very easy to look at a list of signs and symptoms and pick out something on paper. But when you're dealing with a patient in front of you, sometimes this picture cannot be so clear. So again, we're typically taught about these cholinergic, or our sludge, our dumbbells, our killer bees, so the things that are going to kill us, which are the bronchial secretions, bronchospasm, and bradycardia. And even within that, the normal cholinergic toxidrome, not everyone knows that there are also nicotinic receptors. And that can also confound the picture because you can see, as listed here, in the muscarinic, and the thing that we learn is that people typically have small pupils, but if it works on a different receptor in the body, we might actually have big pupils. They can be bradycardic and they could also be hypertensive, which we don't typically think of. So these confounding pictures based on what we classically learn can make the clinical diagnosis a little bit more complicated. But again, that is why it is so important that if something isn't fitting, or just, that spidey sense is going off, that something doesn't naturally fit, take a step back and reevaluate and look at the entire picture, because maybe there is something else going on. Similarly, when we talk about an opioid toxidrome, we're all very used to hearing about the opioid epidemic and fentanyl and heroin and how that can make you decrease your respiratory rate, your level of consciousness is decreased, and you have very small pupils. New to the scene are some newer agents called alpha-2 agonists, and these are things like xylazine and medetomidine, and these are things that are now commonly combined in the illicit opioid supply, which can, again, start to complicate our picture. Now, there are some drug supplies where we're seeing pure xylazine and medetomidine. We're seeing combination of fentanyl plus one, or sometimes we're seeing a combination of all of these together. And what we're talking about is, again, is a medication similar to clonidine, or if anyone's ever worked in the ICU, dexmedetomidine or Precedex. So similar agents, they're alpha-2 agonists, but they can cause that small pupil, sedation, but we really see a lot more bradycardia and hypotension. So again, the important thing to know is that it's important to know what our toxidromes are, but we really need to be careful. And when we are evaluating patients, especially in those first minutes to hours when we don't have a full amount of information. Next slide. So what we can kind of take away from this case is that we really need to avoid that anchoring bias, that we want to identify these patients early so that we can give them appropriate antidotal therapy. We also know that some of these newer agents, whether it be the new nerve agents like the Novichok agents or the newer xylazine and medetomidine alpha agonist agents, these can really start to blur some of our classic toxidromes, and that we just need to be very vigilant about what we are seeing in front of us. Next slide. So moving on to our next case, we're going to talk about a case of patients who present with wheezing, difficulty breathing, and eyes burning. And you might already start to be thinking about what this potentially could be. So again, adapted from a real case, we had 3 patients who arrived by private vehicle with wheezing, chest pain, difficulty breathing, eye burning, nose burning, nasal secretions, all just, very having a lot of trouble breathing. They all live in the same neighborhood, and they had gotten an alert on their neighborhood app that there was a fire at a local business earlier that morning. They hadn't really thought anything of it. So in the emergency department, patient 1 is wheezing, has chest pain, but they are responsive to albuterol, and they have normal oxygen saturation, don't require any supplemental oxygen. Your second patient has a lot of wheezing, no real response to albuterol, lots of retractions. You have them on 4 liters nasal cannula, still having some issues with hypoxia. And then your third patient has no wheezing or stridor, but their eyes burn, their nose is running, but not really in any respiratory distress. That's, excuse me, 2 hours later, we hear that there is a pool fire or a pool chemical plant that caught on fire, and that was causing problems. Next slide. So again, this is adapted from a real event that occurred near Atlanta, where I live. And I can tell you that despite this happening many miles from my actual house, I could feel what was in the air. I could smell it that morning. And there was sort of a cloud haziness on the highway. And people were pretty worried because no one knew really what was going on. So there was a lot of people starting to call the poison center or maybe present to hospital saying, I don't know what this is, but there is something going on and I don't like it. Next slide. So what ended up happening here? So this incident originated from a small rooftop fire that happened early in the morning at this chemical plant company. And the fire activated a sprinkler system that doused these water reactive chemicals. So trichloroisomeric acid and dichloroisomeric acid. So they got wet. These chemicals do not like to be wet, and they will ultimately combine with the water and create chlorine gas and other chlorinated vapors. And so what happened was this fire happened, all of this really tons and tons of chemicals got wet, and then just put these clouds of chlorine gas into the air. Then when you have chlorine gas out in the environment, it can interact with other just nitrogen that's in the environment and the air, and also created something called chloramine gas. So now we find out that we have this massive chemical chlorine gas release in the environment. So 4 hours later, you have about 48 other patients that present with very similar symptoms, all in this vein of kind of irritation, redness, eye burning, difficulty breathing. And our 3 patients ultimately end up doing okay. 1 gets admitted for the ICU because of the breathing. 1 gets observed and discharged, and the other is admitted for continuous albuterol. Next slide. So now we're talking about how there was a chemical plant that had known chemicals for pools that caught on fire. So was this an accident or was it terrorism? If there's a nerve agent release, then generally we know that that's a terrorism event, but a chemical plant that catches on fire, what do we do with that? Now, unfortunately, the most common scenario for terrorism with involving toxic industrial chemicals or toxic industrial materials, that scenario is generally going to be a release of a large volume of gas. And it's going to cause a lot of, again, morbidity in your patients that you're seeing, some mortality, but also a lot of fear and a lot of chaos, a lot of wounded, kind of walking well, patients presenting to the hospital. So these are very difficult situations that we would deal with. Next slide. So how are we going to recognize this toxidrome, right? We have an irritant gas. So again, in this case, you could smell the chlorine. Almost everybody knows what chlorine smells like. But what if we didn't know the agent, or we couldn't identify what that smell was, and we needed to identify the patients based on presentation? The way that we go about this is that we determine, or with irritant gases, is that we look at their water solubility. So because we have a lot of water in our eyes, our nose, our mucous membranes, our lungs, when you have something that is highly water soluble, it doesn't necessarily matter what the gas is. We know that you're going to have a rapid onset of symptoms because that chemical is going to react with all the water, and you're going to immediately know it. You're going to have that burning. You're going to have those uncomfortable sensations. So you end up having really good warning properties with these highly water soluble gases, and it's going to tell you, hey, I don't like this. I need to get out of here. You can get some upper airway irritation, but generally because it's so irritating, you leave, you leave air and you don't have a lot of that lower lung injury. And our classic examples of this are going to be things like ammonia and then things like chlorine. With our low water solubility, so it doesn't react well with water, you can have a delayed onset of symptoms. We're not going to know that it is bothering us because it's not going to irritate us. So we might stay in that environment longer, breathe in more, allow it to get into the deeper lung spaces, and ultimately result in a lower lung injury. And for us, that the most common thing we think of is phosgene. Next slide. So I'll leave you again just with when we're trying to identify what an agent is, it always isn't as important what the actual agent is, but what we can do is try to identify certain properties that will allow us to understand what type of PPE, when we need to evacuate, how we want to treat those patients. And with that, I will pass it back to Dr. Kazzi to talk about some additional toxidromes.
Thank you, Dr. Kieran. This was great. I agree with what all the stuff you mentioned about the limitations and the advantages of toxidromes. And I want to remind everyone that the best way about this is to always reassess the victims. Don't be afraid of changing your mind about what you think the chemical is, and have an open mind of what toxidromes look like. And sometimes you have incomplete toxidromes rather than complete ones every single case. So I'm going to start with the first scenario that I've pulled from the literature. This is based on a real event. I've modified it a little bit to a soccer type event, since we are all preparing for the FIFA World Cup in the United States and North America, and as well as Central America. And I described to you here a case where a doctor at a small community hospital is notified. It notifies the health department that this doctor is seeing 6 people who presented to his emergency department throughout the afternoon with vomiting and diarrhea. So this is a gastroenteritis type presentations. However, this doctor was suspicious because these 6 patients have all attended a social gathering at a soccer fan venue that morning and ate some turkey, ham, egg sandwiches, assorted cookies, etc. This event was attended by about 30 people, so it was not a very large fan event. And 6 of these people right now had presented to the emergency department. Later that evening, an additional 6 people with similar gastrointestinal syndrome had presented. And now you have 12 people, and 4 of them are admitted to the hospital. 3 were transferred to a regional medical center for intensive care. So this is a pretty significant cluster of illness for a variety of reasons. One of them is a large number of people. Number 2, some of the severity that we're seeing requiring intensive care. Definitely within 16 hours, when you have 2 people developing multi-system organ failure and 1 patient dies of this, that's definitely a very significant public health incident. And you see here that you have a clinician that noticed this, so that's very important, recognized the issue and reported it, communicated this to the health department. So these are already 2 important steps in this. And just want to share with you that this is really, this happened before in the United States. I changed a lot of the locations and circumstances, but the mortality and severity is correct, is from a real event. So when you see this as a clinician, of course, number 1 cause, food poisoning. These people ate something that had gotten rotten, a food that was not properly preserved, or maybe there's a viral illness, a bacterial contamination of this food. That's really the first thing that should come to your mind, because that is the most common. But remember, sometimes when you see an onset of illness very rapidly occurring after the ingestion of the food item, you have to think about either a chemical or sometimes toxins that have been preformed by the bacteria or the living organism and have really contaminated this food that was ingested to get this rapid onset. Because otherwise, you do need an incubation period for the virus or the bacteria to develop into an illness causing the signs and symptoms. So toxins are definitely something to consider. Chemicals as well, with these what we call these rapid onset gastrointestinal illness. Now, don't forget also, as a good clinician, ionizing radiation. Now, I know that in the past this would have not been something that people think about, but considering the assassination of Alexander Litvinenko with radioactive polonium and him presenting initially with a gastroenteritis, I think more and more clinicians are going to think of radiation as a cause of gastroenteritis. Now, I may be biased because I love to talk about radiation all day long, and maybe that's not true, but I feel like clinicians are more and more familiar with vomiting due to radiation exposure. So faced with this differential diagnosis, you want to try to look for additional clues that can point you in one direction or the other. And I've had to do this in my career because I work a lot outside the US as well and all over the world, particularly in the Middle East, in Eastern Mediterranean region, as well as Southeast Asia. And I've had to face these clusters of illness and I had to think through this. Now, when you think of toxins, like I said, they can produce this rapid onset illness, gastrointestinal illness. You do hope to see additional findings. Now, in the case of Mr. Georgy Markov, who was assassinated in 1978 with a ricin injection into his thigh, this ricin was extracted from castor beans, and that injection here, the route was important. The fact that this was injected in his body led to this severe illness. He did have the gastroenteritis, but he also had rapid development of multi-organ failure and died within 2 or 3 days after the exposure to the toxin. Now, I had last week in the state of Georgia a patient that ingested 3 ricin bean pulps, thinking that they will help the skin texture. Now, this person developed gastroenteritis that was self-limited overnight at the hospital and then was discharged safely home. And you can see here the difference in the severity, probably because of the route that was used and also the potency or the concentration of the ricin toxin in the pulp of that castor bean that she cracked and ingested. And now, sometimes you look for other signs and symptoms that happen with these toxins. Some of these biological toxins that are produced, for example, in fish, like ciguatera toxin, which is elaborated in certain type of fish that ingest parasites in the ocean, such as barracuda fish, tuna, snapper, grouper. These large fish that eat smaller fish can elaborate the ciguatera toxin in their meat. Now, when you have that type of gastroenteritis that happens also rapidly, you do have additional signs and symptoms. For example, severe itching, body aches, and typical neurologic manifestations with hot-cold reversal. I've had patients that will say to me that when they were showering with a hot shower, it felt cold. When they wash their hands with cold water at the faucet, it felt hot. Same when they drink a hot beverage or a cold beverage, the temperature sensation was reversed. Now that's pretty classic to me for ciguatera poisoning. That helps me differentiate this from a regular, run-of-the-mill Staph aureus toxin gastroenteritis. Along the same path, you look at saxitoxin, which is also present in shellfish. It's also present in sea turtle meat. We've had outbreaks of saxitoxin poisoning that will have this paralytic shellfish poisoning, a variety of signs and symptoms that can happen there. And most notoriously is pufferfish poisoning with the tetrodotoxin. And you see here a fish in the picture of one of my patients in Lebanon. This person had he owned a fishery and he fished that fish and he knew about it. For some reason he ate it and he developed the tetrodotoxin poisoning, which in his case he was lucky that the dose was very small. But I've had also patients in Oman as well as in Lebanon that developed severe hemodynamic collapse with coma and requiring pressors. And in my case, I dialyzed these people in those situations because I thought the tetrodotoxin could be dialysable. But you see how you're adding these different signs and symptoms can guide your diagnosis. And finally, botulinum toxicity or botulism. That's also something that you should not miss because of the descending flaccid paralysis, the dilated pupils that you add to a potential gastroenteritis picture. And we just had a case of botulism last week in Baghdad where a patient ate a beef liver that was fermented in vinegar at room temperature for 11 hours. The person ate that beef liver and developed sickness that first day right away, became intubated 3 days later, and we had to rush him an antitoxin from Egypt to try to reverse the course of the toxin effect, although it was still delayed. And I still don't have any final update on him. This is an active case. But you see, the paralysis here for botulinum helped me think about botulism as opposed to, for example, ciguatera toxin. Although there are some case reports of ciguatera toxin-induced paralysis, it's not very common. Often I get asked the question, how do you know this is a tetrodotoxin poisoning? Why can it be botulism? Because I've had a case where somebody ate a fish, and developed tetrodotoxin poisoning. This was before the time we knew that the pufferfish existed in Lebanon, for example. And my colleague thought this was botulism. But remember that the botulinum toxin doesn't necessarily cross the blood-brain barrier. Tetrodotoxin, on the other hand, does. It causes true coma, whereas botulism does not cause true coma. You may look comatose, but your brain is not comatose, and you're able to respond to stimulation. So that's one of the things that you could do to differentiate tetrodotoxin and botulism. Also, tetrodotoxin would cause severe hemodynamic compromise, requiring pressors and life support. So this mumble jumble that I just presented to you here, just to show you the intricacy of these toxidromes and the importance of adjunct signs and symptoms in your assessment. Add to this chemicals. When you think about chemicals, now you're looking at metals, and the metals can cause a gastroenteritis symptoms, but also they have their own findings, such as neuropathy. They can have chronically exposure, can have skin changes, hair loss. Often these are missed because they can cause delayed full toxidromes. So be on the lookout for metals as a cause. And the cluster that I discussed with you right now was an arsenic poisoning in Maine when arsenic was placed in coffee at a church. Don't forget about your pesticides. I won't belabor these because Dr. Kiernan talked about them, but they do contaminate food supplies and cause a cholinergic crisis as well. And last but not least, remember ionizing radiation. Mr. Alexander Litvinenko ingested polonium-210, lacing his tea, developed an acute gastrointestinal illness, and died, 22 days later, 23 days later, from multi-organ failure due to radiation exposure. The trick with Mr. Litvinenko that he ingested an alpha emitter that evaded a radiation survey performed on his body and his urine because the alpha particles are very easily shielded by body fluids and did not really get to be detected by the handheld detectors. They were used at the hospital in London before his death. So I hope you enjoyed this brief presentation of the gastroenteritis. I'll move on here quickly to a sudden collapse. And the sudden collapse can be preceded with a gastrointestinal syndrome as well. But when you see a sudden collapse, you have to think about the dose people were exposed to and the route. Typically, inhalation of a gas is the best way to collapse suddenly. A large dose, of course, would cause more dramatic symptoms than a lower dose. But we are thinking here about cellular poisons like cyanide gas or cyanide itself produced by ingesting cyanogens that are present in some of these prunus species that I'm listing here and other type of vegetables. You can also release phosphine gas by mixing phosphite salts with acid or with humidity, and that's a very common cause of suicide in India and Iran. We've had these cases also in the state of Georgia. Dr. Kirk alluded to hydrogen sulfide gas released in suicides, the chemical suicides in cars, where you can mix also chemicals to release hydrogen sulfide. You can see hydrogen sulfide release as well in the petroleum industry, in pipelines, as well as in manure pits. And don't forget about arsine and stibine. These are a couple of my interesting poisons here that can cause delayed onset toxicity with severe hemolysis. I share here with you a case that I had in Pakistan, where you see the hemoglobinuria. Basically, you have lysis of red blood cells causing this red urine, and you can see on the right that patient's blood work, his hemoglobin was 5 grams per deciliter. So these are potential gases that are less well known. They can be produced by mixing metals with acids and can cause this delayed hemolysis. I finish up here with a real incident also in an airport. I won't disclose the location, but this incident, people presented with skin changes, skin blisters. This could simply be an insect bite, could be a chemical burn, could be a thermal burn, could be an electrical burn. Of course, these people did not have any of these exposures. They work at the same place, and they were investigating a leakage in an office at that airport. I added to that, those two patients had eye findings. These are not their eyes. I did not want to show their face, but they had similar findings in their eyes, especially the one in the middle, a mild conjunctivitis. When you add those two things together, you may be thinking about a virus illness causing a rash. You think about all of these together, but then if I tell you they also have respiratory complaints, you add all of that together, and now you're thinking about this is potentially a sulfur mustard exposure, which was the case of this cluster of illness in this airport. This sulfur mustard exposure again causes These skin blisters that are delayed in their onset. Remember, these workers that I saw that I was involved with in that cluster had been exposed, let's say, in the afternoon on one day, and presented to the emergency department early morning the next day with these findings. The eyes and the skin were the first findings. Those two victims did not have respiratory complaints because of the dose that they've been exposed to was low enough, luckily for them, not to develop the bronchial effects or the pulmonary effects. But they did develop these long-term complications of these blisters that healed in that matter. Same, the eye injuries also can develop long-term consequences from this. Sulfur mustard exposure is not a simple thing to be exposed to or to treat, and can cause long-term sequelae as well. Again, blister agents are not only sulfur mustard, there's also lewisite and phosgenoxime. For the sake of time, I'm not going to be able to go through these. These are not as commonly reported as mustard. Remember, when you see a burn that's not thermal or electrical, that's not chemical or immunologic, and it's not something like a sulfur mustard, for example, always think about ionizing radiation. Radiation is notorious for causing delayed onset skin burns that will often elude the proper diagnosis. Now we are going to move on to the last section of this presentation. We are a bit short on time, so I'm going to ask you to stay for an extra 10 minutes, if it's okay with you, after the hour. If you cannot stay, this is recorded, and we appreciate you staying as long as you can. But as you are assessing these clusters and preparing to manage them, you must don the appropriate personal protective equipment and perform decontamination. At this point, I'd like to bring it back to Dr. Kirk for a brief comment about his experience tackling the issue of PPE and decontamination. Dr. Kirk.
Thank you. I wanted to just give you a few general principles that I feel like I've learned along the way, and I go back to the four key actions. The first one is stopping exposure by all means possible. Just to take a look at the basic concept of what is exposure. When people in a hazardous materials or a terrorism incident, often the two routes of exposure, they're going to either breathe contaminated air or they're going to get something on their skin. You can have ingestion, as Dr. Kazzi mentioned, gastroenteritis type pictures, but more often than not, when people are exposed, it's going to be inhalation or skin exposure. And that exposure, the amount of exposure is considered a dose, just like if you ingested 100 Tylenol tablets, it's a dose that the patient's receiving. And that dose is going to determine how sick they get. So stopping exposure by all means possible is really minimizing the exposure or minimizing the dose. There's many, many ways to do that. The three big ones that we'll talk about are PPE for yourself, and then shelter-in-place evacuation, and then patient decontamination. Back to that point, delays matter. This is a first aid procedure, and if you look at the quote on the right, the most important and most effective decon of any chemical exposure is that done within the first minute or two after exposure. This is a quote from the United States uh, Institute of Chemical Defense, where they deal with the chemical weapons in the military and how to treat these patients. And their alarm of how rapidly you need to perform decontamination. So first and foremost, it's a first aid procedure. Just like someone's on fire, you want to extinguish those flames. Secondly, you also want to prevent spread of it to others so it's not contaminating other people. And the goal of decontamination is rapidly moving people that are contaminated, safely and quickly moving them to an area where they can get definitive care by healthcare providers who are wearing this safe but the minimal protective ensemble they can, so that they can actually perform their duties. So with that, I'll turn it back over to Dr. Kazzi.
Thank you, Dr. Kirk. And again, apologies for running late, but I hope you can stay with us as long as possible. This is recorded. Thank you for talking about this, Dr. Kirk. And decontamination, just as a reminder, will vary in terms of resources and what is being done. We also know that a good majority of victims will evacuate on their own and head to the hospital without decontamination. So we need to remember that although decontamination is preferably done at the scene, it may have to be done, it will have to be done at the hospital, and we should be prepared for that. I just want to introduce a couple of new concepts for you to look up later on your own at your own leisure, particularly referencing the PRISM decontamination guidance, which classifies victims in three categories depending on their ambulatory and ability to take care of themselves status, C1, C2, and C3. And I want to just emphasize what Dr. Kirk said. In this PRISM guidelines, it's very important to remove the clothes immediately after the exposure, which really emphasizes what Dr. Kirk said about the critical value of these first 2 minutes and performing this immersive decontamination right after the exposure. And in this specific immersive decontamination procedure, of course, dry decontamination is the default option. So after removing your clothes, if you are contaminated with a non-caustic liquid, then in that case, you can go ahead and just do dry decontamination using any type of absorbing material or pads or paper towels. And that's very important. Now, you still need the wet decontamination for caustic chemicals or those in like solid form or powder form. And in those cases, you do have to use wet decontamination. But the default is dry decontamination in the immersive decontamination phase. Now, beyond that, once you start looking at the gross decontamination, for example, using a ladder pipe system that will be followed also by a technical decontamination later on, this gross decontamination with the ladder pipe system that you see here takes about 10 to 15 minutes at least to set up. And by that time, there may be a reason why the chemical would have evaporated and the ladder pipe system gross decontamination may not be useful. And our PRISM guidelines provide an Aspire tool that I invite you to look up on your own. This is all freely available online to figure out if you know what the chemical is and you know the time of exposure and your time of beginning the gross decontamination, it may not be worth it. And you can use these graphs to decide based on the time you're about to start this gross decontamination and the time from exposure, depending on the chemical, if it's worth it to do it or would the chemical have evaporated by that time. So this is an interesting tool that I thought you could use in the PRISM guidelines. And finally, of course, when you get to the technical decontamination phase, it's going to vary if the patient is ambulatory or not. Of course, PPE here for this decon team is essential. But at the end of the day, do not forget your active drying afterwards, after the end of the decontamination. And for the sake of time, I will skip through this slide. At this point, I'd like to turn it over to Mr. Ricky Shutter to share with us some of the physical and online resources that are available for us as we prepare for a chemical emergency. After his presentation, we are going to move rapidly into the Q&A session. And thank you. Mr. Shutter? Mr. Shutter, can you hear me?
Oh, is that coming through now? Are we good?
Your voice is quite low.
Yeah, it's
Now
thing
it's
it
better.
does. Yep, there we go. Okay, so as I was saying, it's very difficult to follow such fantastic presenters, but I will do my best. And I'm going to make this fairly concise to keep us pretty close to on track. But yes, I have brought with me just a small list of resources. It is going to kind of lean more heavily, of course, into public health and healthcare, because I do have a bit of a bias as far as those resources go. If we do next slide, please. All right, so just jumping right into it, we'll start with public health at all levels are a vast resource for not only the healthcare, but first responders and other response partners. And that's state, local, tribal, territorial, like I said, all levels. We have, and I can speak only for Georgia specifically. Other states have different hierarchies for their public health and different resources. So I do highly recommend for those of you that are with EMAs or other response agencies to reach out to your public health agencies and forge those relationships. But we have health departments stationed all over every county in Georgia. We're divided into 18 different health districts, each with their own capabilities, fairly standardized, but also some specialized depending on the situation and relationships that those districts have. the main things that we are fantastic at is coordinating with your healthcare resources, providing medical staffing for shelters, medical evacuations. Here in Georgia, we have a specific special shelter program set up for patients that are in medical needs. So, they may be non-ambulatory and need special supervision or care. We also help to facilitate our healthcare coalitions, which are just large groups of hospitals and healthcare facilities, and they're broken up into various regions within our state. That each region is headed by a regional coordinator, a specific hospital or agency. And these coalitions help to coordinate between all of those local hospitals as well as the neighboring regions and can facilitate rapid hospital-based medical and clinical toxicology. Now, one of our main focuses for public health as far as a chemical response goes is the ChemPACT program. As it's been mentioned several times, the name of the game in responding to chemical incidents is speed, especially when it comes to treatment and decon. So for ChemPACT, we have, and that's what this little picture up here is, we have two different types, and you have your EMS ChemPACT, which only has enough doses for an estimated 450 patients. This is also primarily for the first responders themselves. And then we have a hospital package, which contains more for more patients. It's worth noting that these are kind of your primary doses. So this is what gets you started and gives you a buffer while we request more resources, which is another thing public health is able to do, is coordinate the request for resources from the Strategic National Stockpile or vendors, whatever the need may be. Now, these are pre-positioned all over the state, all over the country, and they're designed to be within a certain distance of everywhere. I think the furthest distance is about 12 hours when you're getting out into remote locations. But depending on the density of your populations, you may have more kits or less kits. And then I want to give a big shout out to the poison centers. I know they were mentioned previously, but especially in Georgia with the Georgia Poison Center, we have a fantastic relationship with them between us, DPH and the Georgia Poison Center. And they offer a lot of resources. Most of the population, of course, knows them as, if you have contact with a chemical and you're not sure what to do, call them for that information. And they're obviously very great at that, but they also offer plenty of other services. We have partnerships with them. At one point, they actually calibrated our radiation detection devices. We have some mutual agreements with them for helping to field phone lines for when a big emergency happens. And they offer a lot of reach back for us as well for healthcare professionals. And I know Dr. Kazzi is very, very well ingrained in that system. So if there's more questions about what the poison centers can do, I would lean on his expertise there. Next slide, please. And then I just wanted to list out some, and again, this is not an all-inclusive list, just some examples of other resources that are less healthcare focused, specifically for chemical incidents. So your Environmental Protection Agency, and here in Georgia, we also have an Environmental Protection Division from our Department of Natural Resources that'll do more of your on the ground at the scene type response. They handle the air monitoring, sample collection. They may do ground surveys to sort of quantify or qualify the area of effect that's been affected depending on the kind of release. Of course, your emergency management agencies will be sort of your nerve center. So that's, your emergency operations centers, things like that. EMAs are there to coordinate everything that's on the ground and above. Fire and EMS agencies are obviously going to be very important because, again, speed is the name of the game. So fire, the hazmat teams are going to be your front line for doing that decon and triage for patients that are in a release area. And then I put a little bullet down there for the civil support teams. Again, this is another state resource that if your agencies aren't already working with, I highly recommend forging that relationship. The CSTs are a unit within the National Guard that this is their whole focus. This their bread and butter is hazmat, CBRN type response. They have excellent people that know exactly what they need to do. They have a lot of toys and equipment that go above and beyond what most other agencies will have. So they're a very good reach back and augment to your response capabilities. And then the next slide is just a couple of websites for your own exploration after this. Got Chem website, Asper Tracy, CDC, which of course is a huge resource as far as training. They've also got infographics, things like that for not only chemical, but radiological, bio, anything you could need for response activities. They've probably got a video or something about it to help your planning. And that'll be it for me.
Thank you, Mr. Shutter. That was a great overview of the response resources. And these website links are going to be available for you to click on afterwards. I will be providing a PDF handout of the slides. Back to you, Dr. Forestier.
Thank you so much to all our presenters. I want to go ahead and open this up for a Q&A session. In the interest of time, I'm just going to answer a couple, which was, the question of will the slides be shared after the presentation? And we're going to work with all the presenters in order to ensure that these can be posted on the internet with their permission and have it readily available for you. So this is the first EMS credit, which you can scan the QR code, and the CNE credit will be available. And there will also be one for CME as well.
And now flip between those slides, Dr. Forestier, as you take in the questions.
Yeah, of course. And so for claiming credit, you have to attend the activity in full for which the credit is sought. You just have to complete the post-activity evaluation by June 5th in order to receive the certificate, which will be emailed to you within 7 days of completion of the certificate. And then you also need to fill out and complete the QR code right here in the evaluation for your EMS credit. So it looks like the first question in the chat is for you, Dr. Kirk. And, an audience member asked if you could clarify the time parameters for the use of the ChemPack on site versus at the emergency room once a patient has been transported. And is the administration of that ChemPack at the emergency room too late?
Yeah, that's an interesting question for several reasons. When ChemPack first came out, there were other programs that actually provided communities with a advanced cache that they could use. And it's really important, particularly for the responders, people running into it, that they may want to have something available to them running into the event. And it does take a little bit of time to mobilize ChemPack. So one of the important things is that recognition point. The moment there's any consideration that could be a nerve agent, even if you're wrong, I think it's worthwhile that you go ahead and start mobilizing it both to the scene and to hospitals, both in both cases. And you need someone, public health or poison center, to really, take a step back and see where are the casualties collecting, because if it's going to take time to get it to the scene, a lot of those patients may already be at the hospital, so there'd be a lot of wasted effort to move it to the scene when the patients are no longer there. So having some real-time uh, tracking of where people are when you're able to get it there. It is quite a challenge. The better it is getting it right at the scene when they need it, but practically you can't have it out in the field at every point. I know some communities I worked with in the past with special events actually had mobile units where they were able to bring it out during the event and have it in closer proximity to the actual crowds that were present, and then put it back into a safe, environmentally controlled place afterwards. There's a lot of logistics that go around that with that.
Perfect. Thank you so much. And so with that being said, we'll go ahead and open it up and give it about another minute. If anybody has any last minute kind of burning questions that they would like answered by any of our speakers, please put it in the chat.
I want to acknowledge Dr. Casavant's comment about nerve agents and first generation and that classification. But I also want to acknowledge the presence of Colonel Jawad Soleimani, who have worked with him in Iraq. Welcome, Colonel Jawad. Thank you for joining us. And he's commenting that the emergency response guide is an excellent tool for the scene response, and I agree with you. This emergency response guide is particularly for our scene responders, and it's available for download online. And it provides you with some of the initial protective actions depending on the chemical and the placards that you're identifying on the scene.
Perfect. It looks like we have no further questions. So with that being said, we all just want to thank you so much for your time and attention during our presentation here today, and thank all of our speakers, and specifically Dr. Kazzi, Dr. Kirk, Dr. Kiernan, Ricky Shutter, and a special shout out to Frangelica Amaker for putting all of this together. We will email out the CME QR codes and have this readily available for download, and we thank you for your time and attention today.
And please join our website, SRDRS website, where you find resources, particularly curated for the FIFA World Cup event that we are going to enjoy in the next few months. Thank you.